And so I've been asked to talk about the subject of starting a family. I think one of the most important things for you all to realise that as anybody who has MEN1 should be under the care or have been seen in a regional genetics service. So if you're at the stage of thinking about starting a family and you want to talk about your options, what you should do is contact your genetics department and ask for an appointment. And what they will then do is go through what the options during pregnancy or thinking about reproductive options are. Certainly in Manchester we have something called a register system. So we are able to contact children who we've tested when we see them when they're sort of 11 or if they're RET mutations at a young age. And usually we will try and see them when they're around 16, 18 to go through what the inheritance of the MEN is and then to also talk to them at that point about what their options are. But we usually end the conversation where there's, if you are thinking about starting a family, phone us up and we'll arrange to see you. I think that's the most important thing, is to get people aware that actually they should access the people who can give them most appropriate advice. As you're aware, there are MEN1 and MEN2 and they give slightly different clinical presentations. Because they're managed differently, the ages at which one would offer genetic testing as a predictive, as opposed to a diagnostic, are different. And then that impacts, therefore, on what you are considering to do in terms of starting a family. They're both inherited and autosomal dominant inheritance. And as you've already heard, we've all got 2 copies of either the RET gene or the MEN1 gene, because actually they're very important in terms of development. You develop MEN1 or MEN2 if you have a mutation in one copy of those genes. And essentially, if you have a mutation in one copy, you're called a heterozygote. So you have a change in one of a copy of the gene. And patients who have that change in the gene, irrespective of which disease it is, either completely have all the features of the disease or express a number of features of the disease. With dominant inheritance, you usually see that someone who has MEN1 or MEN2 has an affected parent. The caveat with that is that with MEN2B, quite a lot of patients, something what we would call a new mutation or a de novo mutation. So the mutation's origin in that patient, and then you would worry about their children. It can affect either sex, and it can be transmitted by either sex, and that's essentially the definition of autosomal dominance inheritance. And so if you look here, what you've got are, for the sake of argument, we'll say it's the RET gene, which is MEN2. What you have is a person who's got MEN2 and they've got that little red blot to show that there's a change in that RET gene. And they've got 2 copies. And when you make eggs or sperm, those copies and those pairs of chromosomes and pairs of genes separate, and you pass on one to each child. So what you can see is that you can either get the normal copy, and that goes to there, or you can get the one that's got the fault on, and that goes to there. And then you get the other copy from the other parent, which is normal. And so what you see statistically, out of the 4 options, 2 of those options are affected. And that's why you have a 1 in 2 or 50% chance of inheriting the gene fault. And that's common to all autosomal dominant inherited conditions. And that's the reason why you would be told that if you've got the condition, your children, each child, will have a 1 in 2 or 50% chance. And that's independent. So it doesn't mean if you've got 2 children, one will have it and one won't. It's an independent tossing of the coin for each child. So in terms of considering your options when having a family, there are a number of different ones. You could do what most people, certainly historically, have done, is to have a child and then test the child at the appropriate age. You could consider prenatal diagnosis. You could consider preimplantation genetic diagnosis, and I was told to try and concentrate a little on that today. You could think about IVF process using either a donor egg or a donor sperm for the person who's affected. Or you could consider adoption. So there are lots of options. So I don't think people now should consider, if I've got a genetic condition, I shouldn't have children. There are ways of having a child, either one that's biologically related to you or not, who doesn't have MEN1 or MEN2 if that's what you want. So you could get pregnant in the normal way. And then test the child for the change in the gene at the right time in terms to manage that child. And there are very clear guidelines in terms of genetic testing of children as to when you would offer testing. And you only offer to do a predictive genetic test on a child if the result of that child has an impact on how you deal with it. So essentially, you would only offer testing to a child if you were going to put them into a screening program, if they were positive. And so for MEN1, the guidelines changed a couple of years ago. Beforehand, we were routinely testing at about 11 because we wouldn't start screening until 11, whereas now, because the guidelines would suggest that you should start screening from 5, we would offer genetic testing from the age of 5. Wouldn't do it underneath that, and what we don't do is do genetic testing to try and reassure parents, which is what quite a lot of people come and ask me. They say, well, I'd like peace of mind, and you think, you might not get it. And actually knowing you've got a child who's affected with a condition before you put them into any form of screening for a few years can be very difficult. For MEN2A, we would offer testing before the age of 5 because with that particular condition, you want to remove the thyroid as a prophylactic operation before 5. With MEN2B, because it's a much more aggressive form of thyroid cancer and it seems to occur much earlier, you would offer predictive genetic testing from around 6 to 12 months of age. And then you would manage the child appropriately. So with this way, you essentially take your chances and see whether the child's inherited the gene change or not. Prenatal diagnosis, and this is something that's offered a lot for a lot of genetic conditions. Essentially, you get pregnant again in the usual way, and then you think about testing that pregnancy at about 11 weeks of pregnancy, using something called Corin-Willis sampling. You may have heard it referred to as CVB, which is Corin-Willis biopsy. And essentially what you're doing is taking a little bit of the placenta, which is the same genetic cells and makeup as the baby, and you then test those cells. There is an assumption that if someone is thinking about CVS or CVB, then you would choose, or it would be considered that you would not continue with that pregnancy if it was affected. So at that point, you would consider termination of pregnancy. And the reason that that's a bit of an assumption is because actually there are risks associated with CVS. The miscarriage rate is about 1%, and that's 1% over the background miscarriage rate. So unless you're going to act on that information, there'd be a little point in taking a risk of the pregnancy. And once they've got the tissue, what they then do is culture it up, extract the DNA and do the genetic test, and then that will give you a result as to whether the fetus is affected. That takes around 2 to 3 weeks, which means that if you are then thinking about terminating an affected pregnancy, you'll be doing that at about 14 weeks, 13, 14 weeks of pregnancy. And the aim is to try and get that through the system early enough for women to have a medical termination as opposed to a surgical termination. And there are different ways of approaching this. So there's something called the transabdominal way, which is essentially where you've got your ultrasound scan of the fetus and you put a needle in through the abdomen to try and get to the placenta. There are, this is probably the most common way of doing this, but then there's another approach which is the transcervical, so that the needle goes up through the cervix. And the reason for doing that will be if the positioning of the fetus or positioning of the placenta was such it was very difficult to get at from a transabdominal route. It's not pleasant, but a lot of women choose to do this for a number of different genetic conditions. And then you come on to pre-implantation genetic diagnosis. So this has always sounded like a very attractive option. It's been around for around 25 years. There has been a notable increase over the last few years in terms of cycles that are done. A lot of the information I'm about to present was given to me by Alison Lashwood, who's a genetic counsellor based at Guy's, which is one of the big PGD centres. But there are 20 centres licensed to perform PGD in the UK. Depending on your regional genetics department, it'll depend on where you end up having PGD. So for example, in Manchester, our patients get their initial workup in the satellite unit that is in Leeds, but all the work is done at Guy's in London. So the patients come down here for egg retrieval and for embryo transfer. So in order to be included for PGD, there must be a definite molecular diagnosis of MEN1 or MEN2. That family needs to have been seen by a regional genetic service, and it's the regional genetic service that will then make the referral into the PGD service. Women have to be under the age of 40, and that's based on, because of this data here, which is from general IVF, but what you see is the pregnancy rates under the age of 35 are significantly better than over 35, and over the age of 40 it just doesn't work. So patients over 40 are not accepted. Bearing in mind the length of time it takes to get through the system to actually get to PGD, you need to be referred really when at maximum age of about 38, 39. A female has to have a BMI in the healthy range, need to be non-smokers, and the couples need to have been living together for a year. NHS England came up with a policy document regarding PGD funding in 2013 with the aim of trying to make equity of access across England. Of course, it's NHS England, doesn't apply to the devolved nations, although Scotland tends to often follow. The current NHS policy is that if you have unaffected children from your current relationship, you will not get funding. You will only be funded if you have children that are affected from the current relationship. And that there is no funding for couples who have a child who is currently untested. That has brought around a major conflict with the genetic services, because actually if you see a couple who've got a 2-year-old who've got MEN1, I would not routinely test that child until they were 5. And it's happened with a number of other conditions, and certainly there's another condition I look after when I wouldn't again test the child till they were 5, and I had my hand forced by the funding agencies because they refused to contemplate funding unless I tested that 1-year-old. I was extremely unhappy about that, as were a lot of my colleagues, and we have pushed, and we are hoping that there will be a policy revision in the next version, which will be 2016, with the assumption that if you have a condition which is a later onset, so onset not in a baby, then you are allowed to have one child and then be funded for another, on the assumption it's autosomal dominant. If you have 2 children, one will be affected. But you are funded for one child, so you are funded to have one live birth. Currently, the costs of PGD are £12,000 per cycle, and you will be funded for up to 3 complete cycles to achieve one live birth. So if you have a live birth from your first cycle, that is all you'll be funded from, even if you have frozen embryos. So you will then have to, if you want to have further children, self-fund using the frozen embryos, and that's coming out at about £1,500. So you will be offered up to 3 cycles unless there are some medical reasons during the first cycle of PGD which suggests that the ovarian stimulation isn't going to work and you aren't going to produce enough eggs. So it's not straightforward in terms of the funding. And what happens is patients are referred from the regional genetic service. They'll have a consultation either at the main centre or at a satellite centre. In some conditions you need to reapply for a heavier licence at each time, but MEN1 and MEN2 are licensed. Then have to have the laboratory testing, then need to have the medical assessment, and then you need to get to the start of your cycle. So the whole process is very long and drawn out and will take up to 12 months, which is why I suggested that if you are thinking about PGD and you're in your mid to late 30s, you need to get referred by the time you're about 38, ideally. And that timeline can vary depending upon a number of issues. And so what happens initially is that you get down regulation of a woman's hormones so that she stops ovulating naturally. You then get ovarian stimulation. Then have ultrasound scans to look at the development of the eggs and make sure you've got a number of different eggs. You then get egg collection. And in some women, they produce quite a lot of eggs. In some women, you can go through this sort of cycle and not produce any eggs at all. And once the egg's been retrieved, you then get fertilisation using something called ICSI, which is intracytoplasmic sperm injection, so essentially fertilised outside of the body. and that will take around 3 weeks. And then you look at the growth of the cells, and at about the 8 cell stage, they will remove a cell and test it. And essentially the biopsy is you take a little bit of that cell, you then test it on a molecular basis to see whether that cell has the family mutation. And then all the embryos are frozen. Bear in mind that you may go through all of that process and not have any eggs or any blastocysts that are unaffected. So you may have up to 8 eggs which have been fertilised and have grown and been tested, but if all 8 are affected, there will be none to be transferred back. And even if you go through that and you have a lot of eggs, and if they are all positive, you are not allowed to say, I don't care anymore, I just want you to put one back because I want a baby. So you are agreeing by this process not to have an affected embryo transferred back. So that whole process again takes a number of weeks. And then once you've had the biopsy results, you then need to get the woman ready in order to take the embryo transfer, and again you get suppression of her normal hormones and then addition of other hormones in order to maintain the pregnancy, get the embryo transfer, and then you need to wait a few weeks later to see whether that embryo has stuck essentially and whether there's a positive or negative pregnancy test. This is data from guys, and what you've got is from the data they had were 921 stimulated cycles. You then got number of those where you retrieved ovaries, it had dropped to 863. You then work out the number of cycles where you got to a biopsy was 820, and then the number of those that you got to transfer, it dropped to 726, and the number of those which resulted in a clinical pregnancy was 304. So the drop-off rate is quite phenomenal. I asked for live birth rates, and I do find this really difficult with a lot of IVF units. They give you lots and lots of different data about lots and lots of stages of pregnancy, but actually the thing you guys want to know is what is the likelihood of having a live baby at the end of this? And I got a very long email with lots of explanations as to why they couldn't quite give me the rate. Can't quite understand that. But essentially, a clinical pregnancy does not necessarily equate to a birth, because a clinical pregnancy doesn't account for the natural sort of rate of miscarriage one would get. But what they are then quoting in guys is that your clinical pregnancy per egg collection is 36%. What they haven't said that is how that's related to the initial cycle that was started. And so I think it's just worth remembering that whilst PGD is an option, it's a very attractive option, it's not an easy one. And a lot of patients have started the discussions about it and then chosen not to go ahead. If you were thinking about using donor sperm or donor egg, it would still require an IVF procedure, and you'd still have all the associated issues with that and the sort of lower live birth rate, which is currently about 28%. But if you were going to use donor sperm or donor egg, that would not be funded and it would need to be self-funded. And then the other option is the adopted route, which some people choose to do. I'd like to thank, Alison Lashwood, who's a counsellor at Guy's, who's given me a lot of information, and then the diagrams were from a book from the Greenwood Genetics Centre. Thank you.